And it's going. Okay, so good morning, everybody. I'm Sandy with the Parents of Children with Special Needs Network. And today we're talking with our Helping Hands program, which is the Part C Early Intervention program. And we have the director, Roseanne, wave, and also Arlene and Celestina. Did I get that right? Okay, yeah. Okay, so I'm just going to turn it over to you to share a little bit about your program and what you do.
Well, thank you, Sandy, for this opportunity to share our services with our community. So I'm Roseanne. I'm the program director for the Helping Hands Early Intervention Program under the Department of Health. We're known nationally as Part C. So who we are service providers we're an early intervention team. We provide services for infants and toddlers under the age of 3 that might have a disability or might be at risk for a developmental delay. We work in all 5 areas of development, which is communication, physical, cognitive, and we do social emotional and adaptive self-health. We work with a lot of the programs that are under the Department of Health, which is our sister programs. We work with the Helping Babies Here program, which is our local EDI program. We work with MCH. We work with McD, the Aying Manuia program, and sorry about that. And we work with children that are with a medical diagnosis. So say, for example, a kid that is cerebral palsy or is referred to us that has a shoulder dystocia, or a child who is around 1 year old and doesn't have any words or isn't speaking or babbling or jargoning, or children who are at 2 years old and are not walking or not sitting. So we have 4 specialists on board on our team that we work closely with, and they're the ones that help screen the children that are referred to us. Yeah, and so we also work with our local pediatric clinic, and they're also the ones that refer to us, and we work closely with the pediatricians with all the children that are referred to us from them, and as well as with Sandy and their local parent in regards to training families and just advocating for their rights and the services that are available to them on island. I'm going to turn it over to Arlene. She's the program manager. She's going to talk a little bit about the eligibility and our screening process. You're mute.
Sorry about that. Hi again. Okay, so like Roseanne mentioned, we do get referrals from multiple agencies. So Helping Babies Here, LBJ, parents walk in. And so usually how it works with the process here is, let's say for an example, a parent will walk in to refer a child. Usually what we do, we take the information down, parent's name, phone number, email address, if there is an email address, hospital number, village, and then what we do is we would process the referral. So we have a 45-day timeline where we have to complete everything before the 45 ends. So there's the referral process, and with that process, it goes to Tina first, which is our child find. She'll be able to talk about it too. So we'll process the referrals, and then the cases come to me where I assign them to the service coordinators. So then the service coordinators will then make the calls out to schedule the intake and the assessment. So with the intake and the assessment, this is where we get information from the families about the child. And then with the assessment is where we determine whether the child is eligible or not. Let's say the child is found eligible for services. What comes next is called the IFSP, or what is also called the Individualized Family Service Plan. And so with this IFSP, we talk about goals, what the families, this is where the family will come in and share their concerns, what goals they will be able to want to work on. And we're kind of going from there. And so with the, like San mentioned, we have 4 specialists. Joyce being the only one here, our PT on island, and then the other 3, we provide services through telehealth. And so the assessment is done via telehealth. And now, sorry, with the IFSP to then restart services if the child is found eligible. Kids will, sorry, babies and children, they will come in. Sometimes we would assess them and then found not eligible. We would also put them on monitor. So what this means is they come in, we assess them, and if we see that they're performing at age appropriate and they're not needing services at this time, however, due to their birth history, we put them on monitor for 4-6 months. And then with the reevaluation will come up, and some of them will be eligible for the program, and some we would just exit them from the program.
And just to add on to that, Sandy, so the services that we do provide here, Part C, are at no cost. So all the services from the assessment to all the service coordination to the other interagency referrals, they are all done at no cost. And I know I mentioned before that we do work with a lot of our interagency programs, but really to be referred to the program, anybody can refer, just so long as the parents are aware and they consent to it. So say, for example, it's a family member or a grandparent or somebody from the church that sees a child that's showing some signs of delayed in any developmental area, they could always inform the families that they would like to make a referral, and then they make the referral to us. But the thing is, when it gets to us, we still make that effort to do that first contact with the family, just to be sure that the consent was given for the referral for the services.
Sorry, I forgot to mention, I went straight into the process, but when we say the assessment, there are areas that we look at. So there's 5 areas that we look at. So we physical, this is where the PT comes in and assess. So this is where we look at the child's muscles, whether they're crawling by 6 months, if they're sitting, beginning to sit or cruise, stand. So we look at physical, and then there's the communication. There's occupational therapists. This is where we adaptive. We look at adaptive. So this is self-help skills. So, is your child able to use the spoon to feed himself, or is he using both hands to play with the toy? So toilet training, and then there's also feeding with the adaptive. There's cognitive. So this is usually how the brain works, whether baby is tracking or is baby looking when baby hears a sound. And then the last one is the social emotional. And then so this is where the behavior comes in. So those are usually the 5 areas that we look at and we base our assessment on. So if a baby comes in or a child comes in, and let's say there is a delay in the communication and the adaptive, that child is then deemed eligible for services. But those are the 5 areas that we focus on. And yeah, is anything else?
Yeah, good.
And Sandy, in most cases, when a child is referred, it's for a specific concern. So a referral could be for what my child is a year old and is not babbling at all. But although that's a specific concern, we take a more holistic approach to where we screen all 5 areas. So at the assessment time, all 4 specialists are present, and we screen for all the 5 areas of development for that child, regardless of the specific concern that was brought in.
Great. Okay, is there anything else? Tina, did you want to share something? I've just been taking a few notes and things as a parent that I might ask, so I'll ask those at the end, but.
Okay, thank you. I'm Celestina, just trying to find for Part C. My job, mostly I am the one that I've received the referral when the referral comes in, Is it either by email, no matter if it goes to Roseanne or Arlene, they will forward it to me. Because what I see, I'm like the frontliner of our program to meet the parents. So what I have to do, I have to make sure all the informations and what the parents concerns about. And then I will call back to the parents seeking their consent. If especially when we get the refer from the LBJ clinic or from HPH, all my first thing to do is contact the parents to make sure all the informations are correct. And then I got the parents, let them know that we got the referral from LBJ or from HPH, and ask if they were being informed that baby will be referred to us. If they said no, then I have to explain them our service as San and Lynn explained. Then if they consent okay to have baby evaluate, then from there I will do the process, mostly the paperwork. Then I will document all those conversations with the parents, and even asking them about their other contact phone numbers, because that's what we see a little bit harder to us, because every time people can change their numbers. So if, for example, if we got the refer for like about a week and then I call them, there are times that I hardly get hold of the parents. Then we have to come out of our own idea of looking at the Well Baby Clinic, just to see if we can get the accurate information, if the parents change their phone numbers, their villages, stuff like that. So my part is to confirm everything before I assign it to the program manager, which is Arlene. Then from there, to make sure the SC, when the SC comes to contact the parents to schedule the evaluation with our therapist, make sure all the informations are like accurate and right, especially the phone numbers, but directions to the homes would be the SC's part. So that's mostly what I deal with. And then when we come to there is another part that I'm coming in, because once the referral is done and every information is well prepared and ready to assign, by the time that babies turn 30 months old, that would be another time that I comes in the scene. So I have to schedule the transition meeting with the SPED and ECE, and I have to, that by that time the child's information will come back to me, and then I contact them. So I am the one, like the bridge to the transition. I email them and schedule with them. So if the parents, and that transition is depends on the parents' consent as well. If they want to do it at home, so we can go home. If they want to do it here in the office, so all those I have to coordinate the parents, and then I let the SPED and ECE knows about that. If the parents happen to change the dates and the location, so that's all what I come in, and then I contact the transition team about the location and time if the parents decides to change it. Oh yeah, so far those are what I'm doing now with our program. I don't know if San and Lingy can add on if I missed something. Yeah, and that's from me, Sandy.
Okay, so what I wanted to do is just go through a few things. Some of these might be new parents that aren't familiar with some of the wording and acronyms. So the first thing I wanted to just address is what early intervention is. And early intervention is being able to meet a child's needs that may have a disability, or like you said, maybe at risk for disability, and try to provide some sort of services or engagement with the child to help them to catch up, to catch up in their development. Because the earlier you can intervene, the earlier you can help a child, the more likely they're going to be able to overcome some of those obstacles that they might develop. A child that maybe hasn't been assessed and treated for years, and then you suddenly try to change a bunch of behaviors or habits or contractures, the longer you wait, the harder it is to correct those problems. So the earlier we can get to those children, the better the outcome will be with the treatments that we offer to them. So that's what we mean by early intervention. When you talked about at risk, can you explain that a little bit more? What do you mean like an at-risk child?
So an at-risk child is a child that is born premature. Prematurity is a risk factor for potential delays, or a child that was born with low weight. So full term, low birth weight, extensive stay in the NICU, or a child who, say for example, was born to a mom that was tested positive for substance abuse. So those are some of the things that, those are some of the risk factors for those kids. So those are the most common ones that we're working with right now. But if a child is born premature, low oxygen level, low birth weight, or if they were born to a mother, or just exposure to substance abuse. So those are like at-risk factors or at-risk children.
That's a really good thing to bring up, because a lot of young women these days are exposed to drugs, and they may not realize it. Even certain prescription drugs, if taken abusively or too much during a pregnancy, can affect the child's development in the womb, so that when they are born, their development might be delayed, or they might have neurological, even autism as a result of that exposure to the drug in prenatally. So it's really good that you identify those and then follow them up in case they do develop. I think sometimes families, they don't realize that their child even has this exposure or disability, and, they just end up calling them ulavale, or they're not, and then the teachers don't know either. And so they're treating them like just a student that doesn't have any disabilities and any special needs, and they might be treating them more harshly rather than providing the proper intervention. So it is really important to get the help, right away, so that the child can get every advantage to be able to overcome the disabilities that they might develop. Okay, then the other thing, and you explained it really well, Arlene, the 5 areas of assessment. So there was the communication, which has to do with if the child is developing the communication on schedule. And if they are not, it's really important. I think communication is one of the biggest ones. My own daughter is non-speaking, and I didn't identify early with her the communication. And I think the majority of her behavioral issues were because she was just trying to communicate. And then if she didn't come across, if nobody listened to her verbal communication, her attempts, then she would start using her body, banging walls, biting, spitting, those kind of things. Then they got attention. So she thought, in her mind, that's how I communicate. People don't listen to me when I babble, but people listen to me if I spit, hit, and pull hair, so it's really important, the communication right off the bat, to be able to teach proper social communication so that the kids don't develop these other behaviors. When you talked about the social emotional, there are certain social emotional issues, like especially with autism, where a child may not give eye contact, or they may just be seemingly preoccupied with an activity and not paying attention to anything else, as opposed to behavioral challenges that are related to communication. So that's a really important area of assessment too, that you do. That's good. Oh, I wanted to ask a little bit about eligibility. So if I have a child, a baby, I'm concerned that they might have some delays, but I really am not sure. And I bring them in and you do the assessment. What is considered eligible for the program? Like, it is a certain amount of delay, or?
So eligibility is if you have an established condition, that's an automatic eligibility criteria for EI services. And then the other one is 25% delayed in one or more area of development.
Okay.
And if you're an at-risk child as well, that's also an eligibility criteria for the program.
Okay, that's good. And again, EI stands for earlier intervention. the other acronym you use with SC a lot, and that's service coordinator, correct? So that would be the
Sure.
person that is sort of managing this particular case, this child, and managing and making sure that they're getting the services that they need and getting their updates and so forth. Yeah, so that's the service coordinator. Okay. If somebody wants to bring their child in for an assessment, what kind of documentation will they need in order to register with the program? Like birth certificate?
Yes.
Yeah. Anything else?
No, it would just be the birth certificate. If it is a child that is in the process of adoption, we would need a power of attorney. So that way, of whoever the legal guardian is, so that way we can process the referral form.
Okay. Yeah, that's good. And that happens a lot here. So yeah.
Yeah.
Yeah, a lot of times. My only other question was just, okay, so the child can be referred and enter into the program anytime from birth to, is it 2.5 years?
At 33 months.
At 33 months. Okay, so they can be admitted to the program up to 33 months because generally they're exited the program at 36 is correct.
Yes.
And then they move on to SPED if they need services continued. Yeah.
Yeah. We've had cases where children are referred to us above the age of 33. So we do an interagency referral where we do connect them with SPED and ECE and just letting them know, okay, we have this child and they're getting ready to turn 3. And so we just let them know that there's a child that's heading their way. So that way they can pick them up.
Yep.
And
that's a whole nother YouTube video on the SPED process. So you can look at that other one. Yeah. Okay. I have your website up here. Why don't we just, so if anybody wants more information, contact information, and they're not ready to call or anything, they can go to the website. So this is the home page here with it's like a photo page, is it? You want to go through what I'm looking at?
Yeah, it's a short video of the services we offer. It's in English and Samoan.
Mm-hmm. Okay.
Yeah.
I don't know why it went. I didn't click on it. Maybe I did. Okay.
So that's what our services look like. We
Yeah.
go out with the families, we're on the floor with the kiddos, and then we have the specialist on the, I don't think it was showing in
iPad.
the iPads, but that's what it looks like. We work directly with coaching.
Sorry.
A lot of coaching involved when it comes to services. So the specialist would coach the service coordinators, infant family educators, and the families on strategies, activities that would help the babies and the children achieve their goals. And so it looks like.
Yeah, that's nice. Okay, and then if they want to go to this tab, they'll find out there's a gallery, the staff message from Roseanne. And then service page tells us about the different services, kind of what you just talked about today, right? The FSP, how to make a referral and so forth. And like you said, anybody can make the referral, but you will always contact the parents or the primary caregiver to confirm that with them. What if you get a referral and the family doesn't want, the parent doesn't consent?
Then we have to exit. Yeah.
You have to, yeah. So it's whoever is the primary, the legal guardian, the legal parent, yeah, they make the decision if they say no. Okay.
Yeah.
And then you had some news and events page, resources page, and contact page. So yeah, that's available.
And that's just one of the ways that because they can also do a referral on there.
Oh,
and
nice.
that's just one of the ways, yeah. And
Right
once
there.
they submit it on there, it automatically comes to us. And that's just one way to refer. They could also call the office, walk in, or send us an email using that email that's available on there.
Okay. All right. Well, thank you very much. Anything else you want to add? I'm done with my questions.
No, just a little bit more information on the telehealth portion of it. The families don't have to worry about getting internet. So the equipment are provided by the program. So should they allow the team to come out to their homes, we bring the iPad, we bring the Wi-Fi. Like they don't even have to worry about getting data or getting an iPad set up. The team brings that out for them.
Okay, so services are at the home.
Yeah,
Yes,
even
so
with
it's in the
yes,
natural environment.
Nice.
Yeah.
Well,
Yeah,
that's
and
very good
a
to
lot
know.
of
Mhm.
Yeah, a lot of the times the natural environment, it's not always at the home as well. It can be wherever the child spends most of their days. Sometimes it can be at other family members' home. It can be at the daycare or at the park or at their parents' work. We've had some kids that are with their parents 8 hours a day at work. So it's, if that's their natural environment, then that's where we try to meet them.
Meet them. That's great. Yeah. All right. Services in our physical therapy, occupational therapy. What else?
psychology and
Psychology,
Behavioral and communication.
yeah,
real and
yeah.
communication. Yeah, nice. Oh, very good. So yeah, the earlier the better. Thank you.
Yes.
Okay.
Times for independent living.
All right. So I think I will just, well, I want to stop the recording, but I can't find it. There we go. Stop.